Good morning. This is David Henry. I'm the Communications Manager for the City of Amarillo. I want to welcome everyone to our COVID-19 news conference for the latest in COVID-19 information for the Amarillo community. Let me go ahead and briefly introduce who's on our panel very quickly. We are joined by Amarillo Mayor Ginger Nelson, Casey Stoughton, Public Health Director for the City of Amarillo, Dr. Todd Bell, Public Health Authority, Texas Tech University Health Sciences Center, Dr. Brian Weiss, Chief Medical Officer for Northwest Texas Hospital, Dr. Michael Lamenteer, Chief Medical Officer for BSA, Dr. Rodney Gonzalez, Director of the Amarillo VA, and Jared Miller. We're going to go ahead and open it up to opening statements from our medical professionals who are here on the panel. We'll go ahead and start with Casey Stoughton. Casey, how are you this morning?
I'm well, Dave. Thank you. So I received information this morning from the lab that the Delta variant makes up 97.5% of all of the variants that they see in testing. You know, as we've seen the virus change over time, I think of words that my grandmother has said to me. She worked in a hospital during the polio epidemics, and she says, an ounce of prevention is worth a pound of cure. And she talks about how that they were so excited for the polio vaccine and how she feels the same way now that the COVID vaccine is here. She talks about how they were scared when they were working in the hospital. They had fear. So they were scared, you know, kind of out and about in the community, and about how when the vaccine came, they were able to breathe that sigh of relief. And she talks about how those memories as they were in the past. You know, one day we'll talk about COVID as it is in the past, but the time's not now. We still have work to do. So I'm going to talk about the numbers, and then we'll hear from our incredible doctors. And then the real work needs to be done in our community. We've got to increase our vaccinations. We've got to increase our masking. We've got to stay home if we're sick or if we've been exposed. And that's the hard work of this pandemic, the hard work that we all have to do so that we can talk about COVID like it's in the past, like my grandmother talks about her time with polio. So as of yesterday, there were a total of 40,805 cases of COVID-19 in Potter and Randall County. We currently have 4,172 active cases, and we're up to 822 deaths here in our community. That's a lot of people who've died. A lot of us have lost loved ones, and that's a really significant thing for our community. The 5-day new case average is up to 258 new cases per day. So we're seeing tremendous spread here in our community. We're currently at level red, as all 4 of the metrics are in that level red zone. Yesterday, our GA34's hospitalization percentage was at 18.28%. We have been at over 15% for more than 7 consecutive days. And so in addition to being an area of high transmission as defined by CDC, we're also an area of high hospitalization as defined by DSHS. The rolling 7-day positivity rate is currently at 14%, and the positivity rate at the drive-through testing site is at 46%. I want to make sure I said that right. So we're at 14% for our 7-day positivity rate, and we're at 46% for our drive-through testing site. COVID testing is available here at the Public Health Department. The number for that is 378-6300 to be screened and directed to the test site. And COVID vaccines are also available at many locations around our community, including public health. Currently, we're offering COVID vaccines at 850 Martin Road, and that's the new public health building right next door to our current public health building there on Martin Road. At our building at 1000 Martin Road, again, we got a lot going on Martin Road, but at our building at 1000 Martin Road, we've opened up limited appointments for our STD clinic. Appointments for STD clinic can be made again at the 378-6300. Public Health is also offering TB testing, childhood and adult vaccinations, again by appointment at 378-6300. Many of the services have been closed since the beginning of the pandemic, and we do recognize their importance. The public health team is currently stretched quite thin, and I want to appreciate the dedication of the public health team during this difficult time. You'll notice a lot of services come through our main phone number at 378-6300. It's very busy first thing in the morning. So we're working on a solution to ease the pressure there on the phone number first thing in the morning. So if you call first thing in the morning, if you have a need and hear a busy signal, please give us a few minutes and call back. we certainly want to take care of you. That's all I have today, Dave.
Thank you, Casey. Let's now go to Dr. Todd Bell, Public Health Authority, Texas State University Health Sciences Center. Dr. Bell, how are you?
I'm doing well. Thank you for the opportunity to be here. I was going to take a few minutes today, if it's okay, and talk a little bit about early treatment strategies for COVID. We've got actually pretty good data of how, and we're getting very good at managing patients in the hospital. It's a long, drawn out process, but we've got some amazing staff in the hospital that are able to do that. When we think about outpatient treatment, it's been a lot more muddy. And so I was going to take a moment to run through the some commonly used things or things that have been proposed and talk very briefly just about what the data behind those might be. So the first thing on the list is, and the thing that we have the best data for, is actually the monoclonal antibody infusions. Now, this is if somebody comes to their doctor and they're tested positive and they have some risk factors. So those risk factors can be fairly simple things, but that's the type of treatment that we have the best data that it's able to prevent hospitalization and death. There's one really large study that's had more than 4,000 patients in it in that phase 3 trial for the monoclonal antibody infusion. So if you have COVID, that's what I would talk to your doctor about first. The second thing that we have, I think, the next most data for is something called fluvoxamine. Now, it's something that came out there's a study came out about 2 weeks ago. This is only one study. There was a prior smaller study that was done, but this was a study of about 1,400 patients. It was done in Brazil. And it also seemed to show that we're able to decrease the risk of going to the emergency room with COVID. So again, if for some reason somebody's not able to do the Regeneron infusion and they wanted to do something else, then I would encourage them to talk to their doctor about fluvoxamine. Now, after that, things get really kind of muddy. So we see that, for example, there's been several studies, more than 20, that have been done on ivermectin. Unfortunately, the majority of these studies are small and low quality studies. They don't necessarily prove that ivermectin doesn't work, but it certainly doesn't support widespread use of ivermectin. If people have questions, I would encourage them to talk to their doctor, but I would also strongly recommend that people not start dosing themselves with ivermectin based off of available veterinary supplies. That actually can lead to a lot of issues and overdose and toxicity. The third thing I would just briefly mention is azithromycin. We don't have any data that azithromycin works. It's something that is, it's an antibiotic. It's kind of like putting a weed killer on a bug. It's the wrong kind of medicine. So azithromycin, there's really not a role. Hydroxychloroquine, again, we now have, I think, pretty good data that it does not work. And so there's no reason to go back to the hydroxychloroquine wars of last year. That's one that we can just leave off the radar. And finally, I would briefly mention the use of steroids prior to the need for oxygen. So we know that there's a role in a patient who's severely ill with COVID of using steroids to dampen the immune response, because the immune response that lands people in the hospital is if they have too much of that immune response and we get a hyper inflammatory process, and that causes additional damage to the lungs. Steroids can help in the hospital. However, if we take the steroid before we have that hyperinflammatory response, it doesn't seem to help, and it may actually increase the risk of having complications and ending up in the hospital. The reason is that early on in the course of the illness, we really need that immune system to be there and to be responding. So there are no magic bullets for outpatient treatment of COVID. That's not how biology works. Biology is not built on miracle cures, and there are none for COVID-19. Which leads us to then, I think, the take-home message, which is an ounce of prevention, as Ms. Stoughton said, is worth a pound of cure. We want people to be vaccinated. We want people to utilize masks. We want people to wash their hands and social distance. And that's how you're going to best keep yourself safe and out of the hospital with COVID.
Thank you, Dr. Bell. Let's now go to Dr. Brian Weiss, Chief Medical Officer from Northwest Texas Hospital. Dr. Weiss, how are you?
Hey, morning, Dave. Well, honestly, I'm very concerned about our nursing staff. I've had the opportunity to meet with a number of them, particularly critical care nurses, over the last couple of weeks. And what I'm hearing is is just the recurrent signs and symptoms of post-traumatic stress disorder, or PTSD. And what they're describing to me is general anxiety that hits them when they go to work and it follows them at home, dreams they have about what they see in the ICU. A lot of them are having trouble sleeping, and then just a general change in their demeanor or outlook on life. And clearly that affects not only them, but their families and their children. And you say, well, what's causing this? Well, I think it's really four things. I think first is what they're seeing now in this surge is recurrent trauma. This is surge number 3 or 4, however you want to call it. But either way, most of our nurses that have been here now have seen the previous surges. So it's just a recurrent injury. Second, I think big thing is they're seeing younger patients affected by this virus. And in particular, over the last 2 months, we've seen a number of young individuals die from the virus and leave behind young children or young families. And that's particularly devastating to a lot of our nurses. And third is they're overworked. And when you think about this, a hospital is like any business. A hospital cannot be successful if it's supporting resources that it's not using. So most hospitals, when they're being very successful, they're at normally about 85 to 90% capacity at all times. So that's why any surge like this quickly overwhelms our resources. And those resources are our nurses, our beds, and our rooms. So again, but in the past, if a hospital got overwhelmed, you knew that the hospital next door could help you, or the hospital down the street or in the next county could help you. Right now, we're seeing all the hospitals in the same situation. And so it's devastating to these nurses knowing they cannot provide the care or the standard of care they normally do because we're all stretched as thin as we can possibly be with regard to medical resources. But I think the fourth reason is also very critical. The vast majority of people have no idea what the nurses see in the ICU. What they do see is a lot of death and suffering. And yet they go out in the public and they hear people say, oh, it can't be that bad, or it's really not as serious as you're saying. I think any time that we minimize the effect on these nurses of what they're seeing, we add insult to injury. So my request for all of us is to be sensitive to what our frontline providers are going through, because it is devastating every day as they do their jobs. Let's talk about the numbers at Northwest Texas. So we have 55 COVID patients today. 51 of those have not received the vaccine. So only 4 of them are vaccinated. That's 11% of our licensed beds, but that's 25% of the total patients we have on the acute side of the hospital. And right now in our ICU, we have 32 patients with COVID. None of them have been vaccinated. All right. Now, so we've struggled with ICU capacity until just the last 24 to 48 hours, when we have now received some additional nurses from FEMA, which has been a huge help. So right now we received 17 critical care nurses that will allow us to open up our ICUs to almost full capacity at that point. So our hope is that we'll be able to get more of the holds out of our emergency room, but also be able to help some of our regional partner facilities maybe bring in patients that they're struggling to deal with because of the acuity of those patients. Right now, we have 28 ventilators in use. 15 of those ventilators are going to people with COVID-19. Remember, we have a total of 40 ventilators, so we continue to edge up closer to that limit of how many ventilators we have. In the month of August, we had 16 individuals lose their life to this virus. Now, that is a far cry from where we were back last January and December. We had upwards of 70, but still that's 16 tragic deaths, and in particular because none of those individuals were vaccinated. In fact, since the vaccines came out, we have only had one person die of COVID-19 in our hospital that was vaccinated. Okay, so again, that's what we're seeing is the people who are most being harmed by this virus are those who have still yet to receive the vaccine. Now, in terms of the holds this morning, we had 10 people holding our emergency room waiting for a bed. All 10 of those were critical care patients. The longest one had been waiting over 3 days for a bed. Again, we're hoping this additional staffing we receive the next day or so will help us prevent some of those holds. Right now, there are 38 patients out in the regional facilities looking to be transferred to a higher level of care, namely us, the VA, or BSA. Yeah, out of those 38 patients, 23 are critical care patients, with 15 of those patients having COVID-19. And then 15 are med-surg patients or floor patients, with 8 having COVID. So these regional facilities are doing their best to really support these patients who are, some of them very critically ill out there, they're still waiting for an opportunity to be moved to a higher level of care, such as BSA Northwest or the VA. Now, Casey mentioned about the variants. Right now, 100% of our positives in the hospital in Northwest are the Delta variant. So that's all we're seeing right now in terms of what's affecting the patients here. Now, our lab's been very busy. We tested 370 people yesterday. About 2 weeks ago, we tested 150, maybe 225 a day. Now we're averaging 300 to 450 tests a day. We were at 15% positivity. So continue in double-digit positivity rates. And lastly, we have 24 staff who are currently quarantined because of either exposure or testing positive to COVID-19. So again, we're already limited on staff, and it hurts when we have our staff members who have to stay home and be quarantined because of exposure and possibly not being vaccinated. There's one last thing. I know Dr. Bell's specialty is pediatrics, but I saw an interesting article on children the other day that talked about the concern now is not only kids getting COVID-19, but now this surge of RSV that we're seeing. RSV is a virus we normally see in the wintertime. We've seen it this summer, unusually. And they're saying that at the Texas Children's Hospital, they had 1,600 positives for RSV in the last 3 months, when normally during the summer, they have less than 30 positives per month. So their concern is we're going to see children get co-infected with COVID-19 and RSV. And that makes them all the more vulnerable to the need for hospitalization or becoming critically ill. So again, I think all we can do, everything we can do to protect our children, we need to be doing, because it's not only COVID-19, but it's this RSV virus that's also affecting their health. That's all I have today. Thank you so much.
Thank you, Dr. Weiss. Let's now go to Dr. Michael Lamenteer, Chief Medical Officer for BSA. Dr. Lamenteer, how are you?
I'm good, David. Thank you. Good morning, everybody. I think that the comments that we've heard so far today are all, very appropriate, and certainly similar things you're going to hear from me today related to operations at BSA Hospital. I think that I'll start off by saying the following, that there is some excitement amongst our medical staff and some of our nursing staff at this time. And the excitement is about the availability upcoming very soon of booster vaccinations for the COVID-19 booster. And that is that we have a significant number of our staff that are very anxious and ready now to get their booster vaccinations. We obviously need to wait until we have the official recommendations and guidelines from the CDC and the expert panel that reviews vaccination safety and permissibility for doing this outside of our immunocompromised population who is eligible now for their boosters. But I know myself and many of our other members are very, very anxious and ready to get our boosters now. And the reason that we're very anxious and excited to get them is because we're seeing breakthrough infections, which means that people that are vaccinated are getting infected. Fortunately, those people that are vaccinated that are getting infected are not translating to significant disease, but we don't want any disease. We know that from the people that have been infected by this virus that getting symptoms secondary to native COVID infection can be long lasting. And we're uncertain what the effects are from a long lasting COVID infection. I hear a lot about everybody being concerned about what the lasting effects are of the vaccine. Quite frankly, I feel strongly people should be far more concerned about what the lasting effects are from a COVID infection, a primary COVID infection. Many patients of whom you've heard on these news conferences from our physicians here, as well as other physicians you probably know, patients coming into their clinics complaining of chronic shortness of breath, chronic fatigue, inability to concentrate, mental fog, brain fog, long-lasting loss of smell and taste that goes on for months upon months, not to mention other things that we probably don't know about what some of the long-term effects are from COVID-19 infection, if that person survives the primary infection. So again, there's a lot of interest in many of our staff for getting their boosters. We are excited about that, and hopefully that will be something we can do very soon, awaiting that decision by the CDC. I want to go into a couple other things. We are in a very difficult situation now when it comes to being able to manage patients in our community and our region. This is one of the first times I can remember since being the chief medical officer here now, since 2012, I've been in this role, that we've had to turn away some patients in the region that were having serious health issues. And the reason is we couldn't give them an ICU bed. And that's absolutely the type of bed they needed to be able to manage their condition. And we had to do the assessment to say, do we have a level of care that's appropriate for that patient to manage them? Or does that sending facility need to look somewhere else? Just as Dr. Weiss has said at Northwest, I know both of our hospitals have had to go on diversion for much of the month of August because of the lack of staffing and the lack of bed availability. And what I'm saying is that the COVID burden is translating now to people that don't have COVID being impacted in terms of their access to healthcare. And that is significant. And that is being infected primarily by individuals who have chosen not to be vaccinated and the burden that that's creating on our healthcare systems. Right now, we have 78 people in the hospital at BSA that had COVID-19. That makes up 26% of our entire hospital population. We had 305 patients this morning. Of those 78 COVID patients, 91% of those admitted to the hospital today are not vaccinated. We've been showing statistics on the number of patients across our entire healthcare system here in Amarillo, all three hospitals, BSA, Northwest, and the VA. And the statistics, I think, are very clear in terms of the numbers of patients that are hospitalized who are not vaccinated, the preponderance of those who end up on the ventilator that are not vaccinated, and the preponderance of those that unfortunately succumb to disease and die are not vaccinated. And that is not a shock. It shouldn't be a shock to anyone. And there's no funny math going on there. Those are the hard, cold facts. I also want to emphasize the following. Of all the patients that we have admitted today in the hospital, 51% of those patients are less than 60 years of age. If we look at the ICU population, 45% of the patients we have admitted with COVID-19 in the ICU now are less than 60. 25% of those in the ICU today that have COVID are less than 50. We are admitting a much younger age demographic of patients now with COVID-19, and it's translating to significant disease, especially when they are not vaccinated. We absolutely have had some patients, unfortunately, succumb to COVID-19, and some of whom are vaccinated. It's a very small number. When we review those charts very carefully, those patients have significant, unfortunate immunocompromising diseases or medications that they have to take for chronic conditions, which likely translates to the fact that they cannot mount an innate immune response on their own to fight off infection, and they likely did not have a good response to the vaccine when they got it, which is a very difficult scenario for those individuals, obviously. And it makes us concerned about other individuals who have not been infected yet and are out in our community and are trying to do the right thing and protect themselves with vaccines. And we're worried about those individuals. And that's why we're suggesting they get the booster now. And we're also suggesting that they do things to protect themselves, like masking, good hand washing, avoiding large gatherings, and those types of things. We have received some assistance from the state in terms of RAC staffing. As of yesterday, we received 17 nurses and 9 respiratory therapists. That has been a big help in terms of having us try to get back to our potential capacity for intensive care beds. We still are not at that maximal capacity because we still need more staff support. We're supposed to get additional nurses next week from the RAC, and maybe even the end of this week, which we're excited about. To date, 19% of all the tests we're doing at BSA, both inpatient and outpatient, are coming back positive. That's been pretty consistent through the month of August, and that's how we ended. That was the second highest month in the rolling 12 months, only to be short of the 34% positivity rate last November. Right now, we're using about 55% of our ventilators. Remember that we did some things to augment our vent capacity last year, which was buy more vents. We're also getting some ventilator support from the RAC, which we're very happy about. And right now, we're in good status as far as those go. But the vents don't do us any good if we don't have staff to take care of patients, and we don't have beds because we're being overwhelmed in terms of our resources. The next thing I'll say is that we're back to having a significant number of our staff quarantined, and they're quarantined because they're either infected or exposed. The majority of those that are quarantined are not vaccinated. We're getting a fair number of those that are vaccinated, however, that require quarantine because of a household contact, like a child or someone who couldn't be vaccinated that gets infected. And then we have to have those individuals monitored very carefully and quarantined. And they're obviously high risk to get infected when that happens. More reason why masking outside of the healthcare institutions is also critical. And that is not something that should be a surprise to anyone. The last thing I'll say is that we are at this point, we have been scrutinizing our surgery schedule on a daily basis. And we've had to have physicians delay surgical procedures that are non-emergent for patients at this time. And the reason is because we need to preserve ICU beds for COVID patients and that burden that's in our community. So other patients that don't have COVID are being impacted adversely by having some of their surgical procedures delayed or canceled because of this pandemic. And that is because we're trying to do everything we can to accommodate the need in our community. As far as monoclonal antibodies, Dr. Bell talked about those. We have administered an astounding number of monoclonal antibody infusions in our BSA facilities. So just to check these two numbers, between the beginning of December last year through the end of June this year, we had dosed just about 300 individual unique patients with monoclonal antibodies. From the time period of July 15th through August 26th, we've done 432 infusions of monoclonal antibodies. That is a tremendous number of infusions. That is, I'm certain, preventing a significant number of hospitalizations. If you are a candidate for a monoclonal antibody infusion, which means that you are 65 and older or less than 65, but you have some medical condition, you need to check with your primary care physician if you are exposed or infected to see if you qualify for the monoclonal antibody, because it could save your life. And number two, I'll say that of all the individuals that we saw that succumbed to COVID in the month of August that came to BSA, none of those patients had the monoclonal antibody therapy prior to coming to the hospital. So that was an unfortunate opportunity lost. So again, make sure you're on top of this in terms of touching base with your primary care provider. If you're exposed or infected, get that evaluation quickly, and hopefully we can prevent you having a serious outcome. That's all I have today. Thank you.
Thank you, Dr. Lamenteer. Let's now go to Dr. Rodney Gonzalez, Director of the Amarillo VA. Dr. Gonzalez, how are you?
Doing well, David. Thank you. So I'll start right out with our numbers. Right now, we have 7 COVID positive patients in our hospital, 5 of which are in the ICU and no one's on the vent. I do want to remind our veterans that we do have the COVID vaccine available, and we are doing the booster doses for those that are immunocompromised that qualify, as Dr. Lamenteer had mentioned previously. So we are offering that 3rd dose of the Moderna vaccine. We also have the monoclonal antibody infusion available. So for veterans who do qualify, it is something we can do here at our VA. Next thing I want to mention is this is Suicide Prevention Month. September 1st starts it. And so I just want to reiterate to any veterans who are struggling with some thoughts of suicide or just need to reach out and talk to someone. Don't forget, you can always call us at 806-355-9703, press option 7. If you're concerned with suicide, it's option 2 for appointments. But also there's the Veteran Crisis Line at 1-800-273-8255. Suicide is something that impacts our veterans and our military quite significantly. Statistics show there are 20 to 22 suicides every day of veterans. And, it's something that we want to make sure that veterans know there are places to reach out to. The VA is one, and there are many others. And so just want to remind all of our veterans or family members of veterans, if you know someone who is struggling, please do not hesitate to have them reach out to us. And with that, I'll say thank you to the City of Amarillo for this opportunity.
Thank you, Dr. Gonzalez. We'll now go to members of our media who are in attendance. If you have a question for an individual panel member or the panel as a whole, that's completely fine. I want to go ahead and start with a new media member, and I apologize in advance if I mispronounce your last name, Michael Cavello of the Amarillo Globe News. Michael, how are you?
I'm doing very good this morning. I guess my question, can you hear me? I want to make sure.
Yes, we can. How are you?
Okay. I guess my question is more to the mayor, but anybody else can kind of chime in. With the governor's mandate against masking, unable to make a mask mandate for schools, is there some trigger point at some point that could revisit his decision that we could apply to the state for? And what I'm saying is many school districts are shutting down. I know of very small school districts like Lomita, Texas, Lampasas, Texas. Both of these areas are very small and very remote, but they've had to close down their schools, and we're being surged in our hospitals. So is there some type of trigger point that we could come back to that? And I'm sorry that my question was kind of long.
That's all right. Thank you, Michael. There is no trigger point defined in the governor's orders where his orders would no longer apply. Obviously, there are other cities that have chosen to go a legal route and try to use lawsuits as a tool to get the governor to change his mind. I think our energy is better spent locally in just having communications with our school districts and our parents and our leaders, informing them about the current situation in our hospitals. I thought our medical panel did an excellent job of that today. Anyone who watched this press conference knows exactly what our current situation is, knows the challenges that our medical personnel are facing, and knows the risks that our current COVID patients are facing, especially those who are unvaccinated. So just taking all of that together and knowing that we have limited resources, both time, energy, finances, I think those are better spent in those local conversations, continuing to educate people, business owners, leaders in our community with the facts, and asking them to lead from their perspectives in the way that they feel is best. That's the only choice that the governor has given us at this time. And there is no trigger point where the governor's authority would recede and we would have different options.
Thank you.
Any other questions, Michael?
Yes, I do have one other question.
Yeah, go right ahead.
A lot of the doctors talked about how their hospitals are getting a lot of extra staff. Do we have a timetable for how long that we have these staff members, or is it just dependent on how the cases are?
Michael, I'll tell you. So one thing, I wish we were getting a lot. We're getting a handful, but everyone helps. So I think both us and BSA have gotten, as Dr. Lamenteer was saying, about 17 nurses, which is significant. My understanding is that a lot of these nurses are expected to stay at least through September, but possibly maybe leaving as early as the beginning of October. So again, big help for a month, but we certainly do not have them indefinitely, is my understanding.
And a kind of a rebuttal to that, are we concerned about our long-term impact? I mean, I'm pretty sure we are, but what is your thought on the long-term impact of the nurses that are going through this crisis? Because as was mentioned, the PTSD aspects and the long-term effects that it's going to have on the nursing profession. What are your concerns, or what are you doing to alleviate that?
Dr. Lamenteer, you want to answer that?
Yeah, I'll chime in first, Brian. You can comment. I would say that we obviously are very concerned. As Dr. Weiss mentioned, yes, the things like PTSD, post-traumatic stress disorder, concerned about folks getting depressed, concerned about folks considering career changes because of the risk to themselves and their families, concerns about folks feeling like they're doing everything they can to help patients, which is they understand their job and their calling and their duty, but then patients aren't taking, in all aspects, personal accountability to protect themselves and others. It's frustrating when they're seeing that day in and day out. And I think there becomes a bit of a, what I would say is unfortunately, a bit of an apathy for folks that are saying, I don't want to get vaccinated. I don't believe in it. I don't think it will help. when there's very good data to suggest and demonstrate that it does. And that, I think, frustrates people that are taking care of patients day in and day out. And I can't tell you the number of times we've heard stories of folks saying, I wish I would have gotten vaccinated. I wish I would have known that this is what was going to happen. I wish I would have been able to convince my brother, sister, uncle, mother, whomever. So that we are concerned about that impact that has on the staff long term. And I think you need to also recall that where we are today is not where we were a year ago when it comes to staffing. We have had a large exodus of nurses for different reasons leave our community and either travel and work elsewhere or like I said, not work in the nursing profession any longer, or not be able to provide the hours and shifts that they provided during the pandemic, because none of that's sustainable. To ask individuals to work the number of hours on a long-term basis is not realistic, and that jeopardizes their personal health and their mentality.
Michael, I would just add too is, in talking to these nurses I've talked to, I asked, where did your colleagues go? Did they go traveling? And a lot of them did. They said a lot of nurses have simply left the profession. They took early retirements or just said, enough is enough. Michael, if COVID disappeared tomorrow, it will take us years to replete the number of nurses that we have lost in the last 18 months. Part of it too is that even our local nursing schools have lost a lot of nursing supervisors and instructors. So they've had to reduce the size of their classes because of that. So we're looking at a system that really is way behind in terms of trying to supply these staff members. And it's going to be years before we see the kind of numbers of nurses. As Dr. Lamenteer said previously, you're talking respiratory therapists or nurses. These are professionals that you don't just produce overnight. They take years of training. And that's what we're looking at. We're looking at years before we can get back to the kind of staffing numbers we saw before this pandemic.
Any other questions, Michael?
No, thank you. But thank you very much for all the answers and the candor.
Hey, thank you and welcome, by the way. Let's now go to Dalton Williams of KVI Channel 7. Dalton, how are you?
Good morning. I'm good. Thank you. So my first question is either Dr. Lamenteer or Dr. Weiss can answer. Both of y'all said that we received 17 nurses from the state. Is that split between the two hospitals?
No, that's individually. We have 17 as of yesterday, with more anticipated to arrive. And I think Dr. Weiss has a duplicate number.
And then do we know the number, like the amount of nurses we're getting in the next coming week? Like, do we have a concrete number, or is it kind of just they show up and this is how many we get?
What I was told yesterday by some of our chief nursing leaders is that we're expecting to get a similar number next week, or a fraction of that number. Sometimes folks show up or are anticipated to show up and they don't show up for different reasons. So we don't need to go into, but the bottom line is we don't always get 100% capture on what is reported to come in a subsequent allocation.
Dalton, I would just say that these nurses that are coming, they're coming in a group that we're sharing between the hospitals in Amarillo and the hospitals in Lubbock. So there are two. They're kind of split evenly amongst the four major hospitals.
Okay. And then in regards to the booster shots, for those who may haven't read up enough on it, can y'all kind of give a timetable of when the general public would be available for a booster shot?
Yes, I mean, I think Casey, you want to respond next, but what I would just say is what we've heard to this point, and please correct me, Casey, if I'm wrong, is that the earliest that we'd have available for the general public is sometime in late September.
Yeah, I think that's a great answer. I think we'll know as soon as it moves through the FDA and the CDC process. And once that's approved, then we'll be able to provide that information. And we'll certainly communicate that here and on the Amarillo Alerts website, but it will need to move through those official processes.
And then when the boosters do become available for the general public, is the still going to be just available at the public health office, or are y'all going to open up more clinics around the city to kind of aid with many people maybe wanting their booster shots?
So all of the providers will be able to provide that. The pharmacies have access to vaccine, doctors' offices. So there's a lot more vaccine availability than what was, the first time when we opened the Civic Center. So we'll certainly be able to evaluate the need and be able to adjust, but we will have, we'll be offering vaccine, and then there's a lot of vaccine available here in our community as well.
Okay. I have no further questions. Thank you all so much. Y'all have a great day.
Thank you, Dalton. Let's now go to Aaron Langston of KAMR Channel 4. Aaron, how are you?
Pretty good. How are y'all?
Good, thanks.
First question, something Dr. Bell talked about earlier, and something we've talked about in previous conferences before, but we're seeing more talk of the ivermectin. Is there anything, if you could say anything to doctors or that are prescribing it, or patients who are self-medicating with it, what would you say to them?
I'll take a swing at this if you don't mind, and then Mike, I'll turn it over to you. To patients that are self-medicating, I would say stop. There's not a mechanism, a scenario in which going to Tractor Supply and buying something to treat a disease that yourself is going to be a good idea. So just stop, talk to your doctor. For doctors who prescribe that, what I would say is we've got other things with better data. Again, if the patient can benefit from the monoclonal antibody infusion, send them to get the monoclonal antibody infusion. We've got good data for that. And again, there's even some data again now with fluvoxamine that may be an option as well. I think that there are options that are out there that we've got better data for than with the ivermectin at this point.
I agree 100% with what Dr. Bell said, and I would just add a little bit of additional detail, and that is to say that if you're a patient and you're taking this because your friend or whomever told you that this works and it's safe, again, I go back to something I think I said on one of these press conferences a long time ago, and that is that in basic pharmacology, and one of my best medical school professors said, if there's any drug out there that someone says has positive effects and has no bad effects, that's not possible. Anything you put in your body that is a substance, whether it's quote unquote natural or whether it's synthetic, has the potential for toxicity. And in the setting of ivermectin, number one, we have now case reports in our medical literature where folks are coming in with ivermectin toxicity because they're taking preparations and dosages that are meant to be for animals, not humans. And it's ridiculous that they would have faith in doing something like that compared to a lack of faith in a vaccine, for instance, that's been tested in thousands of individuals and proven to be effective. And number two, for providers that are prescribing ivermectin, I would plead that you stop doing so. And I would challenge you to go back and look at the data on ivermectin to date in terms of its efficacy. And I think if you do that with a scrutinizing eye like you were trained in medical school, you'll stop prescribing ivermectin.
Any other questions, Aaron?
Yeah. It appeared as the Delta variant was first kind of taken hold here in Amarillo, we didn't see a whole lot of deaths. But it seems in the past couple of weeks that that has changed. Is that what you're seeing in the hospitals?
Aaron, I would say, look, one thing is we have learned how to take care of people with COVID-19 better after 18 months of experience. But we are seeing incredibly sick individuals. We're seeing people being prone most of the day, if not all the day, because we can't oxygenate them otherwise. So I would say that people are getting just as sick as the first variant. I think we're just doing a better job of learning how to take care of them and try to get them through the crisis. But please, we are seeing people die from this Delta variant, particularly younger people.
I would say the same. Our overall mortality rate for individuals that ultimately get hospitalized for COVID-19 is the same now as it was at the beginning of the pandemic when we had our largest bolus. And that is somewhere around 13 to 14% of patients that get hospitalized ultimately succumb to disease secondary to COVID-19. And that is a high mortality rate for any condition that requires you to get hospitalized for. We had about 31 deaths in the month of August on my last assessment with our team here at BSA. That is a tremendous number. The majority of those patients are unvaccinated. Some of the patients that succumbed, unfortunately, were vaccinated, but had very immunocompromising conditions at baseline. And that is a significant thing to remember. So the best thing I think that's the difference now is that for those that are vaccinated, we're seeing very mild symptoms for most, unless they have some other condition, as I said, that suppresses their immune system. And the monoclonal antibody therapies absolutely are having a positive impact, I believe, on preventing hospitalizations and severe disease when they're given early. So again, we still use things like Dr. Bell mentioned, the steroids, the remdesivir. There are some additional immunomodulating drugs that have had some good data that we're using in the hospital. These drugs are not the end all be all, but there's some evidence of survival benefit, and we are using those now. But there's a point at which when someone gets to be advanced disease, that no matter what we use, it's going to be up to their innate immune system and their comorbidities to determine if they are going to be able to survive or not.
All righty. And one last question. We're 2.5 weeks into school, and then that's roughly the incubation period for spreading. Are we starting to see more school-age kids testing positive and showing up at the hospitals?
Yes.
All righty. Thank you very much.
Thank you, Aaron. Let's now go to, if I'm not mistaken, Kevin Welch of News Channel 10. How are you, Kevin? Try it one more time. Kevin Welch of News Channel 10. Kevin, how are you?
Can you hear me now?
Yeah, we got
Hello?
you.
Okay.
Yes, we can hear you.
I love technology. So, Casey, can you start out by re-educating us a little bit about hospitalization rates and how they're calculated? Because it seems like on the report card, the RAC number is way bigger than the Potter-Randall number. So can you talk about that?
Yes, absolutely. So on the dashboard, you'll see two numbers. For one is the hospitalization 25 county region, and that is that RAC, the GA34 hospitalization percentage. And what that means is that so last night 18.28% of all hospitalized patients have COVID-19. So it's a very different calculation than the hospitalization rate. The other hospitalization rate that's on the dashboard of 3.34%. That means that 3.34% of all of our active cases are requiring hospitalization. So different calculations, but both very important numbers to know.
Okay, great. Thank you. That makes it better.
Sure.
Is the city screening candidates for booster shots? How do you do that?
Yes, that's a great question. So it's patient attestation. So if a patient comes into our clinic and they tell us that they have that they qualify for the booster shot, that they have one of the conditions that is immunocompromising, then they would qualify for the booster dose.
Okay. And doctors, how are oxygen supplies doing? In some places they are kind of short. Are they good here?
Yes, I have not heard anything at Northwest about a shortage or concerned about a shortage yet.
I agree. That has not been an issue to this point.
Okay. And there was some talk earlier about possibly another monoclonal infusion site. Do we know anything about that?
So we're still working on the details of that. We've put in a STAR request for support from the state on that, but we're working on the details on that. So hopefully more information to come.
Do you know where that would be? I mean, not the address, but would it be a city-run one versus a hospital?
Okay. It would be a city-run one.
And to fund some of these extra hours, and are the hospitals in the city using some of that federal aid money to pay for that?
No, we have very specific grants that pay for our staff.
Okay. And hospitals?
We have not to date. We're working with the hospitals to utilize the TDEMs and also FEMA funds. It would be impractical at this point to kind of compete with the state and all of the other jurisdictions in the state to find those additional nurses where that incentive pay might make a difference. So we're continuing to work and partner with with TDEM and everyone else. Otherwise, the last thing we want to do is waste that money trying to compete with other jurisdictions across the state.
Okay, makes sense. And then on the August 23rd report card, it showed that there were 22% of the deaths were vaccinated people. Is that an anomaly? That seems really high.
Yeah, I remember you're talking. Go ahead, Todd.
So I was just going to point out, so the our older folks, our folks that are at greatest risk of complications, wisdom sometimes comes with age. And so we have above 80% vaccination rate amongst our most vulnerable folks. So if we have someone who is starting off very ill just because of age or comorbidities, then their risk of succumbing to any sort of disease is going to potentially be higher. It's kind of like if we have a boat and there's both folks who are, let's say, a beginning swim team on the boat that chooses to use life vests, and we have a bunch of Olympic swimmers on the boat who don't use a life vest. The boat turns over. It's not surprising that there's some deaths among the beginning swim team that's using the life vest. The amazing thing is that any of them survived if the storm is enough that it also causes deaths amongst those Olympic swimmers. So the point of that is that our folks who are very ill and either may not mount an immune response or have other underlying immune conditions, they're still going to be at risk of disease and death. That doesn't mean that the vaccine doesn't work. It's preventing lots and lots and lots of deaths among those very same type of peoples, but we are going to have some breakthrough deaths just as we see breakthrough infections. Dr. Lamenteer, do you want to clean up my analogy there?
I think that was well stated, Dr. Bell. And again, this is a little bit of a tyranny of small numbers. I mean, to put it simply, if we have 10 people that die and 2 of those folks were vaccinated, we're sitting here saying 20% are vaccinated. Sure, it's a tyranny of small numbers. We have an overall small number of deaths compared to the hospitalizations, for instance, when you look at our COVID-19 burden. But again, what I would say there is too, that the devil's in the details. And that is that when you look at the patients that were vaccinated that have unfortunately passed away after their COVID-19 infection or secondary to it, those individuals are extremely ill individuals with a lot of immunocompromising conditions. And I won't go into the specifics of it in terms of protecting privacy, but these are situations that are not surprising is how I would put that.
Okay, great. That helps a lot. Thank you all.
Thank you, Kevin. This concludes our news conference for today. I want to thank all of our panel members who took the time out to provide this valuable information to the Amarillo community. This is David Henry. I'm the Communications Manager for the City of Amarillo. We'll see everyone next time. Thank you.
Thank you.